Good afternoon, good morning, wherever you are. Thank you all for joining us today for this important discussion. My name is Desta Lago. I am the Global Director of Partnerships at AmRef Health Africa, and very, very pleased to be here today to facilitate this important conversation. I am here in Kenya, and I know some of our speakers are in other countries, which we'll introduce you in a short while. And I think it's really important at this point to say that sometimes in adversity, there's opportunity. And this timely discussion is actually taking place in the midst of the most devastating pandemic of our time. COVID has revealed to us how critical primary health care is to ensure the attainment of SDG 3 and universal health coverage. And while we know that primary health care can meet more than 80% of people's health needs, I think we are really feeling the fragility of our health systems and how critical indeed it is to invest in primary health care today, just so that we can reach SDG 3 and the UHC. Today, countries are investing in strengthening community-based primary health care in response to COVID-19. And that these investments can be leveraged into long-term SDG gains by countries reporting progress at the high-level political forum this week. So we need to step back, I think, at times to see how we're doing and if the pace at which transformation is taking place is sufficient. And what we've learned in the last 6 months is that accelerated investments in community-based primary health care are critical to COVID-19 response and achieving SDG 3. And what this means is ensuring healthy lives and promoting well-being for all at all ages. And in the context of this discussion today, we'll hear about several key elements, including the need for equitable access, the need for using health promotion to engage communities in understanding the determinants of health, the efficient use of technology to enable our work, sectoral collaboration, and then most importantly, community participation. And we also recognize that to achieve UHC, our interventions have to be people-centered, population-based, equitable, and cost-effective. So it's no surprise that we rely on our frontline health workers, including community health workers, because they are truly the backbone of primary health systems in Africa, delivering care directly to communities and playing a pivotal role in preventing, monitoring, and responding to COVID. So to set the stage today for this conversation, we're going to hear directly from a community health worker on the importance and impact of their work through a pre-recorded message, video message. And that would be Namanda Proskovia. Namanda is joining us as a community health worker and is joining us from the Masaka district in Uganda. We'll then, following the video message, we will hear from our panelists, and we have some amazing panelists, really, and I hope we'll get into some very good discussions. So let us first start with a message from community health worker Namanda Proskovia, and then we'll move directly into our panel discussion. So welcome.
Amanya gange nze Namanda Proskovia, ndi musawo asookerwako ku kyalo nga nnyambibwako ekitongole ekya Living Goods mu disitulikiti y'e Masaka, Uganda. Nkola mu maka 409 nga ntuusaayo obujjanjabi ku baana abato abali wansi w'emyaka 5 ng'era nnondoola abakyala abasito enkola ez'ekizaalaggumba awamu n'okulaba ng'abaana bonna bagemebwa. COVID-19 akyusizza engeri gy'empeerezaamu abantu bange nga kati nkyaweereza naye nga sikwata wadde okusemberera omuntu. Ne nnyambala gilavisi ne masiki era ne nteekawo ebbanga erya meters 2, awo ne nkwata essimu ne neekebejja omuntu era ne nkozesa essimu eno okumulondoola. Kirungi okusigala nga tuweereza abantu baffe obuweereza obw'enkizo. Nange ngezaako okwenyigira mu kulwanyisa ekirwadde ekya COVID-19 nga nsomesa abantu obubonero obwa COVID-19 n'engeri gye tusobola okumwewalamu nga okunaaba mu ngalo, okwambala masiki n'okuteesemberera. Obubaka obukyamu bwakabenje nnyo eri abantu, naye abantu bange banneesiga n'amawulire amatuufu. Kikulu nnyo abasawo nga ffe okulaba ng'amaloboozi gaffe gawulirwa mu kitundu kyaffe ku bikwata ku by'obulamu. Gavumenti ya Uganda ne Living Goods bagezezzaako okutuwa ebikozesebwa abasawo ab'enkizo nga nze, era ne tuyambibwako obutakosebwa wadde okutaataaganyizibwa nga tukola emirimu gyaffe. Abantu basanga obuzibu mu kufuna obujjanjabi. Gavumenti tugisa ffe abasawo nga ffekka tetusobola kukikola. Amannya gange nze Nama.
Thank you very much. I think maybe some of us had a little bit of a difficulty seeing that video, but it was a message from our community health worker from Masaka district in Uganda, Namanda Proskovia. If you can hear, there is a chat functionality, and I'd like to just point out to you that the chat functionality is there. So if you have any questions or if you had trouble hearing that community health worker, please type a message to the organizers and we will respond to you. So thank you for setting the tone for us, Namanda. I would like to now move to the amazing panel of speakers that we have today, who will be able to share their insights on how we can leverage COVID investments in community-based primary health care for long-term SDG gains. I am joined by 5 panelists, and I would like to introduce them in advance before I ask each one of them to speak for a few minutes, just to set the stage for us. We have Dr. Salim Hussein with us. He is the head of the Department of Primary Health Care, Ministry of Health, Kenya. Dr. Salim is a medical doctor and public health practitioner in Kenya's Ministry of Health with a passion for public health system strengthening. Dr. Salim is currently the head of the Department of Primary Health Care, and prior he was the head of the Department of Health Promotion, Division of Community Health, and worked as a district medical officer in numerous districts throughout Kenya. So Dr. Salim comes to us with a great deal of experience in the primary health care space here in Kenya, where I am also based. Our second panelist is Mr. Maziko Matemba, who's a community health ambassador of Malawi, and I believe that he is the first. He is a professional public health expert and community mobilizer who has served as a health and human rights campaigner in Malawi and globally for 15 years. Maziko is a champion for comprehensive community-based primary health care and has served as executive director of the Health and Rights Education Program and participates on numerous task forces for community health and RMNCH. The third panelist that we have is Dr. Raji Tajuddin. He's the head of Public Health Institutes and Research at Africa Centers for Disease Control and Prevention, Africa CDC, based in Addis Ababa, Ethiopia. He is a medical doctor with postgraduate qualifications in pediatrics and public health. And in this role, he coordinates the establishment and strengthening of national public health institutes across 55 Africa Union member states and coordinates the Africa CDC Institute for Workforce Development. Taj is heading the Healthcare Preparedness and Countermeasures section of the Africa CDC COVID-19 response and co-chairs the Case Management and Technical Working Group of the Africa Task Force on COVID-19. Our fourth panelist is Dr. Diana Nsumbuga Nambatia. Dr. Diana Nsumbuga is the Deputy Country Director, Community Health Partnerships for Living Goods in Uganda. She is the Africa UHC co-chair, working closely with the governments on the continent and multilaterals to progress UHC. Diana is an accomplished public health professional with extensive experience in health system strengthening and community health programming across African countries. She holds a PhD in public health and has served as an honorary associate professor at Makerere University. And our fifth speaker today is Vicky Okine. Vicky is Executive Director, Alliance for Reproductive Health Rights in Ghana, a network of civil society organizations working to increase access by underserved communities and vulnerable populations to reproductive and maternal health services. Vicky is a women, children, and adolescent health advocate and has led several advocacy initiatives nationally and regionally, including a Pan-African campaign which advocated for equitable access to health and HIV services, and is currently a member of the Primary Healthcare Strategy Group. So thank you very much for an amazing panel and for being here today to share some of your insights with us. And I would say to those of you who are listening in, as we move through the panel, if you have any questions at all, please put them in the chat group. If you look on your screen, there is a chat functionality and we will be taking questions. So any questions that you have, please do indeed put in your questions in that section. I think already there are a few questions that are coming up. I'll ask the organizers to take a look, as some of them have to do with logistics and accessing translation availability and sharing of links. So let us start now with Dr. Salim. Dr. Salim, can you hear me? And let's just make sure we can hear you. Are you there? Dr. Salim. Dr. Salim, can you hear us? Okay, I am not hearing Dr. Salim, so as we deal with some of the technology issues, and this is the age of webinars, a new way of working for all of us. So let me go to our next speaker while Dr. Salim is checking on his mic. Dr. Salim, are you there?
Yes, I'm there. Can you hear me?
Yes, now we can hear you. Welcome, Dr. Salim. So Dr. Salim, the first question I have is for you. I hope you can hear this, and I hope that our listeners can hear you as well. The question for you, Dr. Salim, is that we know Kenya is committed to achieving UHC, has tremendous political will and commitment for this goal, which extends all the way to the office of the president, and I see this every day here in Kenya. And we do know that community-based primary health care is key to making progress towards the goal of UHC. So from your perspective, what is Kenya doing to strengthen community health, and how are you mobilizing stakeholders towards this common objective?
Okay, very much, Doctor. I got your question very clearly. I hope now you can hear me.
Yes.
I think to begin with, as you have correctly put it, actually we have the highest political commitment from the office of the president. Since we started implementing our UHC, the president has been very particular that we should have 100,000 community health volunteers so that we can have 100% community health units in Kenya, so that the primary health care services can be extended, can be accessible and equitable to all. So in terms of Kenya, in other areas that we have actually leveraged on the issue of UHC and currently COVID, we have several documents currently that are pointing to the use of community health strategy and primary health care. Looking at our Kenya Health Act 2017, it clearly states that community health unit is level 1 health services. Looking at our Vision 2030, it clearly talks about a paradigm shift from curative to preventive and promotive, and empowering our communities. Directly in the Ministry of Health, in our Kenya Health Policy 2012-2030, talks about using a community health strategy for basic curative, preventative, promotive, and rehabilitative services. Currently, as we are speaking, we're actually planning to launch our primary health care strategic framework. This we are going to do it on 16th. And more importantly, in this framework, we are looking at having networks, both the public and private partnership. We are looking at how multi-sectoral engagement, and more so we are looking at the health sector in the ministry, looking at teams working together and avoiding verticality. On the same 16th, we are also launching the community health services policy so that community health, primary health services can actually be institutionalized in the health system. So for us, UHC and currently COVID, actually one of the outcome or one of the things we are seeing that it has done for us is health system strengthening, especially at the primary health care level. Currently, as we are speaking, we have managed to sensitize 61,000 community health volunteers on the issue of UHC, the issue of COVID, and the issue of digitalization of the community health information system. As we are speaking, we are training 31,000 community health volunteers so that we can have 100% community health unity in Kenya. The government is also looking at having a digitalized community health information system so that we can collect our data through a digitalized form. We are having a community health bill currently in the nation that goes through. Community health services will actually be financed by the government, the treasury, and the community health volunteers will also be supported. In coordination in Kenya, currently from the national level to the county, we have a community health focal person at the county level, at the sub-county level, up to the community health unit level. We are really looking, the government is looking at institutionalization of the primary health care and especially the community-based services by giving an infrastructure for the other programs to work on. All the other programs have modules that are used to train the community health volunteers. The government is also looking at the Ministry of Health working with the Ministry of Interior at the community health unit level so that our administrators, the sub-chiefs and the chiefs can work at the community health unit so that we can work together in implementation of government projects. So basically, these are some of the things that government, the Ministry of Health is doing to strengthen primary health care and community health services. What we are doing in terms of partners, we have a strategic trust objective in our Kenya health policy about partnership and coordination. So partnership is looked at as a very important strategic pillar in implementation of health services. We have at the ministry level and even at the government level, we have a private-public partnership policies. In the health sector, we also have the health sector coordinating committee where all partners are involved. And our primary health care level, in all our documents, our guidelines and our standards that we develop, we actually engage all our partners, our stakeholders, so that we run with them. During our implementation, especially when we are coming up with our plans, for example, our annual work plan, we make sure that all our stakeholders are part of it, they contribute to it, and they also support us in implementing. In terms of program plans or short-term plans, for example, currently we're having coronavirus in the country, and we have a very extensive community engagement where we have about 13 technical working groups, and in all these groups, we have our partners participating according to their expertise and their interest. So our partners for us, from the policy level, we engage them, and up to our integration level and in our implementation, we always look at our partners to both support us technically and also during the implementation time. At the ministry level, we also have a directorate actually of intergovernmental relations, where currently the counties are great or are our main stakeholders in implementation of our primary healthcare services. So we actually have a whole directorate that can coordinate us so that we work with our partners inside the government and outside the government. Thank you. Over.
Thank you very much, Dr. Salim, and you've actually mentioned several interesting and important areas. You've talked about working within intersectoral, within the various ministries, engaging certainly in partners, the commitment to train community health-based workers and to ensure that you make primary health care accessible to all. And I think most importantly also is that you have developed the primary healthcare strategic framework and you're working within that. So recognizing, of course, that health system strengthening at the community level is critical. The training that you're doing with the investment and commitment of the government, that's very much impressive and important, I think, for everyone to hear in terms of how you're doing. Dr. Salim, I'm going to hold questions for you until any other questions for you until the end. And I'd like to actually go to our next speaker, who is Maziko Matemba. Maziko, are you on? Now, I was just really taken aback, Maziko, to hear that you're actually the first am I wrong or am I right? One of the first community health ambassadors in Malawi, and you've had quite a bit of work sort of mobilizing communities at every level. And so for you, the question that I would have, Maziko, can you hear me? The question that I would have for you as the first ever community health ambassador in Malawi.
Yes, I can hear you.
Oh, great. Okay, as the first ever community health ambassador in Malawi, and having been using your position to accelerate access to quality primary health care at the community level, maybe you can talk to us a little bit about why it's so important for Malawi to increase political will and investments in community health, and how has COVID impacted your work? Over to you, Maziko.
Thank you so much, Desta. Thank you so much. Thank you so much, Desta, and everyone on the call. It's an honor to be sitting here and share my experience, but also my country experience, as Desta was asked. Well, indeed, I'm the first community health ambassador for Malawi. It has never happened before. So the issues are many for me to address, more especially at community level. Let me try to give a background, which can also help maybe other panelists on the call, just to appreciate why having an ambassador. Community health has been one of the areas which was being neglected for a long time in the Malawi health system. Even though in terms of our approach to strategies for health sector, we have health sector strategic plans for many years, for 56 years through our independence period. But in terms of resources for community health wasn't that adequate. In fact, we only had a section as a community health section when 84% of the population of Malawi, they live in the rural areas. So the Minister of Health have been sitting down, reflecting what would be the best way to make sure that we need to invest where it matters most. So last year, they had a discussion. Of course, the discussion started earlier. The Minister of Health with partners and everyone, including myself, we are part and parcel of the development of a national community health strategy, which will end 2022. So 2 days down the line, it was found out that there was no champion or ambassador who could champion the actualization of some of the programs and strategies in the strategy. And the investment wasn't adequate enough. So with that, the Ministry of Health and partners, WHO, UNICEF, and other local partners, AMLEF, they
Maziko, I think we lost you. Can you hear us? Maziko, did we lose you? Can you check your mic? Just when we're getting to the interesting part. Hello, Maziko. It seems that I am losing. Can I ask one of the organizers, please, to turn on your speaker and just say a few words to make sure that it is Maziko and not everyone else whose speaker is not working?
Hi, Desta. Oh, he's back.
You're back. Great. Okay. Maziko, we lost you there for a minute, and you were just speaking about the decision that Malawi made to invest in where it makes most impact, and developing the plans to develop a national community health strategy, and then we lost you there. So perhaps you can pick up from that. Maziko?
And Desta, this is Sarah. It looks like he's offline, that he lost internet connectivity.
Oh.
So perhaps let's move, unless he can chime in, but it looks like he's offline without internet. So perhaps we can move to the next panelist and come back to Maziko when he's able to reconnect.
Certainly, we can do that. So our next panelist is, and this is to be expected. I've been on so many webinars and we've lost contact with speakers and regained them back. So our next speaker, I'm very happy to introduce to you Dr. Raji Tajuddin. I hope that I am pronouncing your name correctly. Dr. Taj, can I call you?
Yes, correct.
Great. Great. So Dr. Taj, I'm hoping you heard us later, but Dr. Taj is the head of public health institutes and research at the Africa CDC. And I know that all of us are working very closely with Africa CDC, incredibly impressed with the progress that you're making and the quick response and the engagement, the regional engagement that you're involved with. So the question for you, Dr. Taj, is we know that strengthening primary health care is a priority for Africa CDC. And we know, of course, that there are many different things happening with this pandemic. So the question I have for you is, how is the COVID pandemic impacting the delivery of primary health care across Africa? And how is Africa CDC helping countries leverage the PHC investments to meet long-term SDG goals?
All right, thank you. Let me first and foremost thank the organizers for inviting Africa CDC to be part of this webinar. And of course, whether we like it or not, PHC should be at the center, or it is at the center of our COVID-19 response. So let me also extend the greetings of our director, Johnny Kegerson, to this great occasion. He will have also loved to be here, but for some other competing demand. So having said that, the Africa CDC is a relatively young organization, which was launched in 2017. January 2017 by the African Union Assembly of Head of State and Government. The other thing we also need to know is that right from outset, we knew that COVID-19 is going to pose a great challenge as far as the continent is concerned, especially in view of the fact that our primary healthcare system is quite weak. For instance, less than 50% of our member states have what we call modern health facilities. You will also agree with me that in terms of budgeting, quite a lot of our member states actually budget less than 10% of their GDP on health, as against 15% that was unanimously agreed upon by all the ministers in Abuja sometimes in 2003. And in terms of human resources for health, you will also observe that as far as the continent is concerned, we are talking of an average of 2 health workers per 1,000 population, as against 25, which is the prescribed standard. And we're also a continent that continues to be plagued with recurrent infectious disease outbreak. As we are facing COVID-19 pandemic, we have Ebola outbreak going on in DRC. We have Lassa fever going on in Nigeria. We have cholera going on in some few countries and so on. So the issue is quite huge. And of course, our primary health system is nowhere we actually want it to be. So as I'm talking to you today, in terms of COVID-19, we currently, have close to 600,000 cases, and this is still going up, you know. Two, we know that about 12,900 or so people have died from this COVID-19, which is quite huge. And the good thing is that close to 50% have recovered from this COVID-19. But the one thing we need to note here is that this pandemic, as far as the continent is concerned, is still on the upward trend. We have not yet reached a peak, neither have we planned to. So in terms of what we have done specifically as Africa CDC, you know, we have been able to come up with a continental strategy and also come up with a continental task force. And we have used a bottom-up approach, sort of, and that's where the primary health system actually come in, you know. And we should also not forget that apart from the Sustainable Development Goal, especially the Goal 3 that is looking at health issues, the African Union also has its own Agenda 2063, whose Aspiration 1, Goal 3, is also looking at equitable access to healthcare. You know, so all this combined together, whether we like it or not, we just need to strengthen as much as possible our primary healthcare. So for Africa CDC, our strategy is underpinned by three key pillars, which is prevention of transmission, prevention of death, and prevention of social harm. And this strategy has actually enjoyed very good political support, right from the head of state level, under the leadership of President Cyril Ramaphosa of South Africa. We also have the coordinating ministers, and we have the technical expertise, you know, that's made up, that is constituting the task force on coronavirus as far as the continent is concerned. Now, still on what we've done in terms of addressing this and looking at it from the perspective of primary health care. Some couple of weeks ago, we rolled out what we call Partnership to Accelerate COVID-19 Testing in Africa. And the goal here is to ensure that we're able to scale up testing as much as possible. In fact, to scale it over about 10 million in 4 months. That's by October ending, we should be talking of 10 million. When we started, the whole continent was, the total testing on the continent was around 200,000. Today, I'm happy to inform you that we are around 6.7 million tests on the continent. And this is driven largely, you know, by our member states. And at the level of member states, you will also agree with me that the COVID-19 response has moved beyond the tertiary healthcare system. You know, it has been disaggregated, you know, it has been decentralized to the lowest level of our healthcare system. And that is where the PHC is coming in. And that is what Africa CDC is talking about. Because for this initiative, we are looking at how do we deploy our health workers. In fact, we have set a goal of deploying 1 million health workers. And these health workers, we are talking of the community health workers, you know, which you will agree with me, these are the people driving the primary healthcare system. We are also talking of risk communication, community engagement. All these are things that are driven at the level of the primary healthcare. Of course, we have also put in place, how do we support our primary healthcare with technology in terms of surveillance, in terms of testing, even in terms of care? What do we need to do to support it? So this initiative is a sort of a very comprehensive initiative that is looking at testing, is looking at tracing, and is looking at treat. And this is going to be driven largely by the community health workers who are at the heart of our primary healthcare system as far as the continent is concerned. In terms of looking at the PHC and this pandemic in particular, as I mentioned earlier on, the PHC, it should be the foundation for health and well-being as far as the continent is concerned. And today we know that 80%, you know, of healthcare system, virtually in all our member states, is driven by the primary healthcare. You know, they provide the first line of defense, and they also provide appropriate response to keep people healthy and safe. And in terms of COVID-19, a lot of member states, you know, through the support of Africa CDC, they've deployed their PHC to support the COVID-19 response at the grassroots and at the community level. And in terms of what is that they are doing specifically, you know, they are helping in terms of testing, in terms of tracing and tracking, and in terms of providing care, especially for the mild cases of COVID-19. Then more importantly, we are also emphasizing the fact that the PHC should continue to run those essential health services. Vaccination, maternal and child health, sexual and reproductive health, HIV, TB, malaria, mental health, non-communicable disease, and so on and so forth. This need to continue, More importantly, that we are moving from emergency phase of COVID-19 to what we call the control phase. So we cannot afford to take our eye off the essential health services, and this is where we want the PHC to play a very key role. And in this regard, Africa CDC has issued a kind of guidance document alongside with WHO on what we need to do to keep our essential health services running, and this guidance document emphasizes the need to come up with a protocol that will govern the delivery of essential health services, especially maternal and child health, sexual and reproductive health, HIV, TB, and malaria, non-communicable diseases. If you all recollect what happened in West Africa during the Ebola outbreak, you will agree with me that although 11,000 people died from Ebola, but close to that same number died from other essential health services because our PHC is quite weak as far as those countries, those countries that were faced with Ebola were concerned, So one of the lessons we learned from that Ebola outbreak was the need to strengthen our primary healthcare system. So to conclude, I would like to say that our countries and donors must prioritize investment in our primary healthcare, and this should serve as a cornerstone of our response and recovery from this present pandemic and any other future pandemic that will, that will come up in the near future. Again, this pandemic should also serve as an opportunity to diagnose, to identify whatever gap that is in there as far as our primary healthcare system is concerned, and fix these weaknesses or this gap. Of course, we must emerge from this pandemic stronger, and this is what Africa CDC is working towards. We've been working tirelessly with our National Public Health Institute to make sure that we address some of these gaps. Ultimately, we believe that Africa will one day fulfill the promise of Health for All and achieve the goal 3 of the UN Sustainable Development Goal, 2, the aspiration 1, goal 3 of the African Union Agenda 2063. Thank you for your attention, and I'll be able for comment. Thank you.
Dr. Raji, Dr. Taj?
Yes.
Okay. Thank you very much. I think that indeed the CDC Africa has taken a tremendous leadership role during this pandemic, and there are so many different initiatives that you've done, the 3 pillars that you've described, and certainly the work that you're doing with member states is commendable. So I really appreciate that. Dr. Taj, I'd ask that if you just stay online because we will have a couple of questions that have already come in for you. And let me just allow me to go back to one of our speakers. Do we have Maziko back? I think we're not able to hear him. Maziko, are you there? Matemba?
Yeah, I'm here. Thank you so much for being patient with me.
Yes.
Yeah,
so before we lose you again, no worries. This is what we work with these days. So yeah, so before we lose you, that's okay. Before we lose you again, if you can just share with us, and of course I can go back and just give you the question that we had asked you is, as we know that you're the first ever community health ambassador in Malawi. And just for us to briefly understand, because I realize our time is also moving, why is it important for Malawi to increase political will and investments in community health, and how has COVID impacted your work?
Thank you so much. In terms of political will on primary health care and community health, through my ambassadorship, so many things have happened. As I mentioned earlier, community wasn't well supported or funded. Investment wasn't adequate enough. And if you look at the budget which was presented when the community health strategy was developed, where 84% of the population lives or they seek care, I think it wasn't adequate enough, even though some of the primary health care programs are under essential health package. But in terms of resources and funding, wasn't adequate. So my involvement, I think on political level, I had to engage a lot of stakeholders because it's one of my role as community health ambassador is to engage high level, cabinet level, but also ministerial at high level at PS level, but also at managers level to feedback them on the programs which are happening at community level, and in terms of resources, but also looking at implementation of programs, whether those programs are indeed addressing the needs and aspiration of communities at primary health care level. So with my position, I've managed, because I think before that I was an ambassador, but with the position, I managed to have a lot of discussion with high-level stakeholders like the UN agencies across Malawi, just to brief them. Normally they invite me to their forums so that I can share what investment is indeed happening on the ground. So it also gives me a leverage that I can be able now, through the position I have, to visit communities, demand reports from district level, primary health care level, so that we can synthesize what is happening and what is not happening. So this came out because of that, and it has also increased the political will. Right now, as I'm talking on COVID-19, COVID-19 at the beginning of the discussion, I think it was more clinical. Through my involvement and advocacy, but also pushing for more resources. The resources now that shifted to primary health care and community level, more especially at community health workers level and other levels. So things are moving in the right direction because of my involvement, but also the position which I have. COVID-19 indeed has impacted negatively to our health systems. Currently, we are here to start do an analysis what has happened, but looking on the lookout what has happened to some of the areas I've visited, communities and health centers I've visited, most of the programs are at standstill because of the realignment of resources from the other resources which were already earmarked for certain programs to mitigate the effect of COVID-19. But also because of how infectious COVID-19 is, most of the people at community level, they're unable to access services because of fear of contracting the COVID itself. So COVID-19 has indeed affected negatively to the health system. I'm hoping sooner we might hear that maybe we have a vaccine or something, so that maybe we can free up the health system, more especially even expectant mothers when they've been admitted at a hospital. I think they're one of the most affected. So in terms of COVID-19, indeed, it has affected a lot of programming, but we're trying to push so that we leverage. Sooner we'll be doing the budget consultation for our national budget, which will be presented in October. And we have come up with a community health budget, which we feel will push at the highest level so that it's be considered in the next level of support to the community level and also community health workers. So in a nutshell, that is what my role has done in initiating the political and also investment, but there's a lot of work to be done moving forward. Thank you.
Thank you very much, Maziko. I appreciate that. You definitely mentioned some critical issues around importance of political will. We have seen how political will has really dramatically it changed the Kenya's environment, and I think yes, you touch on some very important points there. So I appreciate that. I want to now just ask Vicky Okine. Vicky, reproductive health is a critical aspect of primary health care, and it needs to be prioritized. I think we all agree with that in effort to meet the SDG goals. How can civil society advocates such as yourselves ensure that reproductive health services reach the community level, especially with the disruption of services due to COVID? And just earlier, you heard Maziko saying, at the community level, there's fear and some people are not able to access essential health services. So from your perspective, how can the civil society advocates really open up that pathway?
Thank you very much, Desta. Yeah, sexual and reproductive health is very much a health systems issue. And at the heart of the health systems is primary health care, which is where the individual has the first interaction with the care environment. And indeed, as Maziko correctly pointed out, communities or community members are scared of patronizing facilities. And on the other hand, frontline health workers are also scared. I mean, a lot of them are not going to work or, trying to get away because they don't have the necessary PPEs and other things that they need to keep themselves safe. So within this environment, what can civil society organizations do to ensure that communities get the health services that they need? And I think that there are several things civil society organizations can do to make sure that primary healthcare systems are robust, they are fully functional, they are resilient, and they cater to the needs of the users at the community level. And a key role that civil society organizations can play is to work to ensure that sexual and reproductive health is contained in an essential services list or essential services package, which is fully funded by various insurance schemes or other sources of funding that exist in the various countries. And on the list of essential services should be family planning, access to contraception and whatnot. And all of these should be really firmly entrenched with mechanisms to operationalize the benefits package. For example, in Ghana, for a long time, family planning was on the benefits package list, but it was never really activated, and until quite recently. And reproductive health, including maternal health supplies, should be really prominent in the essential services package. And essential medicines related to reproductive health should be part and parcel of the COVID list of essential medicines, to move sexual and reproductive health forward, because achieving SRH is key to achieving the SDGs in any country. We know from the experience with the MDGs that, health system gaps led to the low performance of most countries, most developing countries and less developed countries in achieving the SDGs in achieving the Millennium Development Goals related to maternal and reproductive health. So we really have to take this on board and work assiduously at making the primary healthcare system very responsive to needs of communities. And then traditionally, I think civil society organizations have engaged in monitoring the quality of care or monitoring the quality of services that communities receive. And I think a key role civil society can play in these COVID times is to continue monitoring services, engaging communities to utilize reproductive and maternal health services. Monitoring services involves, at least from the organization we run in Ghana, it involves tracking beneficiary perspectives on their interactions with the care environment. And we can do this or continue to do this towards amplifying the voice or voices of community members, making sure their voices get heard in the policy space in order that change is secured on their behalf. And this is very pertinent now that we are in the control stage of the pandemic. We've all gotten over the initial panic and confusion and that sort of thing. So we need to strengthen primary healthcare systems, and within those primary healthcare systems, sexual and reproductive health. Data is very...
Go ahead.
Yeah.
Sorry, Vicky. Yes, go ahead. I thought you were just wrapping up.
No.
Please go ahead. Please
not
go ahead.
Really.
I want to make sure I get to Diana. Yes, yes.
Yeah, that's what I get for being the last speaker. Data is also very important, data to track the impact of COVID-19 on sexual and reproductive health. And civil society organizations traditionally have engaged in producing data from communities, community perspectives, budget tracking, to follow the money to ensure that the resources are used by the health system to strengthen community systems, making sure that communities are receiving the services that they need. So engaging in budget tracking is also very important, and producing data on community perspectives, as I mentioned earlier, through the various social accountability mechanisms which civil society organizations are very experienced at using to generate data, like scorecards, citizens report cards, and whatnot. So generating data which captures, which highlights what is going on, which also highlights the multiple dimensions of gender and those usually left behind, women and girls' experiences in sexual and reproductive health, would be very important. And we will use such data to demand accountability and hold service providers to account, hold government to account how resources are utilized on behalf of those intended to benefit from the resources. And it's also important that civil society organizations engage health services to understand how sexual and reproductive health issues are being met and how issues are also being addressed. And
Vicky, I'm going to actually interrupt you just because I want to make sure. Thank you very much, first of all. And I think we hear very, very strongly that you're talking about the accountability that civil society organizations have, the need for data and the transparency to some degree, and certainly the investment that we need to make in SRHR to ensure that these are part of the essential health services. So I'm sure I've left out something, but let me just come back to you on the Q&A, since we're running short of time, and I appreciate your time as well. I want to just ask Dr. Diana Subuga Nambatia, and I hope I said this correctly. Dr. Nambatia, question for you. I guess as we're approaching the 1-year anniversary of the high-level meeting on UHC, what progress have you seen in advancing commitments around supportive policies that invest in community-based primary health care?
Thank you very much, Desta. I'm super excited to have had this opportunity to share with you some of our thoughts as we continue to support African governments in really moving forward with the commitments that they made at the high-level meeting. As we're all aware, about 75% of diseases on the African continent are preventable if primary health care is put at the center of planning, budgeting, and implementation processes. And based on that, we have seen strongly a lot of progress has been made by African countries in budgeting for health, increasing funding for health, and particularly funding for primary health care. We've also seen a lot of political will. For example, Dr. Salim, the work that he shared in Kenya, a lot of political will from a number of African presidents in moving forward the work around universal health coverage. Having said that, we still have also seen a lot of progress in strategic partnerships to move forward the work. For example, the work that the Africa CDC, Dr. was speaking to. And so with those so many movements that we have made, we also see that there's so much more that we can do. And I'll use this couple of few minutes to speak to what are some of the things that we think we can even do more. I think there's still a lot of work to be done around supporting governments in adopting co-financing models so that the work that partners together with governments are doing, can be made sustainable. And I know that Living Goods in Kenya, but also in Uganda, have gone into co-financing models with governments, where governments bring money to the table together with us Living Goods, and together we implement community health system strengthening work to make sure that we reach the woman and the child at the last mile. We also have to continue having partnerships that we can leverage so that then we can be able to move this work forward. There are a number of policy guidelines that have been put in place, and I had a number of my fellow panelists speak to them. But I still think beyond just having policies, it's critical that we have core processes around implementation to make sure that the work that is being done moves forward. I cannot underscore the use of data for decision making. We all know very well that the work we continue to do in the communities, it's important that that data gets to the key decision makers so that then they're able to make informed decisions. There's a lot of work that we're doing as partners, but also as government. And so I think in the next couple of months, ahead of the high-level meeting, but also ahead of several other meetings, very well aware that we've just finished a World Health Assembly, which was virtual. It's critical for us to think about building more communities of practices, or even utilizing those that are already existing, to make sure that we continue sharing our learnings, our best practices, so that we reduce a lot of duplication. And lastly, but not least, the role of quality of care. Quality of care, and particularly continuity of services, is very critical, because if we cannot measure the quality, then we're not doing anything. And critical to think about digitization, the use of technology, because we can do so much with technology, maybe even working on use cases that can then be able to provide the community health workers ways and noble ways to move this work forward. I want to pause there and hand back to the chair to continue moving us forward. Over to you, Desta.
Yes. Thank you, Diana, and apologies since we started late. It seems like we're running over, and I hope a few of you, I know one or two of our panelists had to leave, but there are a few questions on the table, and maybe I will ask the remaining panelists who are still with us. The first was, there was this, conversation about community health workers, and it seems like there's a big reliance on community health workers. And one of the questions that we've received is, are there any steps or programs that are out there to take into consideration burnout by community health workers? And also, we heard Africa CDC is working quite a bit with community health workers and training them. One of the big challenges in Africa is that community health workers are not paid typically. So I guess the question on the table for the panelists are, first of all, does the reliance on community health workers cause burnout? And if so, does that, is there anything being done to mitigate that? And then secondly, how do we ensure that our community health workers are compensated? So I open it up to, maybe I'll just come around and ask. I think Dr. Salim had to leave us. So maybe
Dr. Salim is still there.
Oh, he's still there.
He's still
Okay,
there,
well, let me then ask Dr. Salim. There's another question from him as well. But Dr. Salim, I think we've lost Dr. Taj, but Dr. Salim, maybe I start with you on that question of community health workers and the reliance on them without adequate compensation. Dr. Salim, do we have you? Okay, while Dr. Salim is coming on, Dr. Salim, are you with us?
Can you hear me?
Yes.
Yes, I think briefly the issue of over-reliance on community health volunteers or workers who are not being paid, I think it's a big issue. It causes a lot of high turnover, and really there's no accountability for people who are not being paid. So I think one of the things we're trying to do in Kenya is actually to shift most of the function, the mandate of the volunteers to people or community health workers who are employed in the mainstream. So we do like a task shifting. I know it is we are doing it slowly. We have not touched the targets that we want, but we want to move most of the function which are being done by the volunteers, actually people that who are employed by the ministry. And as we are speaking, the government has started recruiting community health workers who will be paid are mainstream health workers in the government, and they'll have a salary. But all that said, personally, I still think that in the community, we really need to think differently in terms of having the household themselves being the family volunteers, so that you're not relying on the link between the facilities, between the health system and the household. Personally, I think it's a high time training some members of the household, for example, two in each household, so they can actually be the family promoters. Thank you. Over.
Thank you very much, Dr. Salim. Maybe I can come now and just find out from Maziko. You work with some of these community health workers in Malawi. Have you seen, you know, how are you working on ensuring that they're not burned out and they're compensated?
Thank you so much, Desta. Indeed, for Malawi, the community health workers, even though in other countries they're called volunteers, but in Malawi, I think uniquely, they're on payroll, government payroll. They're given a salary, kind of a salary as community health workers. It's very unique from other countries that they're not called volunteers, but they're part of the civil service. But I have to listen to say, even though Malawi will pay them at the end of the month, they're still overburdened in terms of their roles and responsibilities. And right now, we are reviewing their roles and responsibilities so that we can see how we can sketch them, so that other professional health workers can also support the community health level workers. Also, I need to say that because of that, currently we are going through a Ministry of Health reforms, and part of the reforms is how do we make sure that the community health workers are not overburdened, but also we have community facilities who are working, because most of the community level facilities are not, they don't offer all the services. So currently there's been decentralization taking place in the country. I'm hoping in the near future, we might not continue overburden the community health workers in terms of their work and others, which is unlike maybe from other countries. But Malawi is doing something around it, but it requires a lot of resources. Hence, my role as an ambassador is also to promote community health workers in terms of their remuneration, in terms of motivation, and mentoring. So that's all my role, make sure that in my tenure, I'm able to motivate them so that they're able to operate and effectively to deliver services as required by the community level. Thank you.
Thank you so much. And I know our time is out. I just would like to ask very quickly, Vicky Okine and Diane, if you can just very, very briefly, 1 minute each, just talk about, you know, we talk about leveraging the investments from COVID to support and strengthen primary health care. So if you can just very briefly, 1 or 2 sentences, just talk about how can we institutionalize some of these learnings that COVID have given us so that we can in fact leverage these investments. Vicky, I'll start with you very quickly, 1 to 2 minutes, and then Diana before we close.
Institutionalizing the investments requires active engagement between civil society and government, continuing with the accountability and advocacy for essential services package with SRH firmly entrenched in there, utilizing data to inform decision making and, you know, stuff related to that. Thank you.
Great, thank you so much. Diane, anything to add to that?
Just wanted to add on and say that it also would mean making sure that there are stronger coordination mechanisms so that there is less duplication, but also to stronger partnerships to ensure that all the heavy lifting is done by, and making sure that everyone is around the table, including the community health workers. Thank you.
Thank you so much, and I thank all of our panelists today. Apologies again for starting a bit late and for having to cut off some of your time as well. I think we've had a very good discussion, and truly it's clear that political will plays a very big part in ensuring that we can leverage some of the investments that we're making for COVID longer term. We see how critical partnerships are, coordinating across sectors, using data for appropriate decision making and for accountability as well. So quite a bit of learning here, and I just want to say on behalf of my colleagues at Living Goods, I thank you all for joining us, and I believe you are more than welcome to include any questions in the chat group that were not answered. I hope that our organizers will be able to answer it for us. So thank you very much to our panelists. Truly appreciate your time, and I hope that we will have continued dialogue again at another webinar series. Thank you all.
Thanks so much, Sarah, everyone. Thank you. Bye-bye.
Thank you. Bye-bye, Jen.